we should start, and let me introduce, before we proceed, I'll introduce you, Prof. My name is Agina Francis Makwabe. I'm the consultant nephrologist working with Africa Healthcare Network in Tanzania. I'll be chairing this session together with Dr. Marine, who is a physician and country medical director in Kenya, and Dr. Frida Mowo, consultant nephrologist and pediatrician working with the Africa Healthcare Network in Tanzania. So I'd like to welcome you all to today's AHN nephrology webinar, and today's series number 102. The topic today is identifying and managing acute kidney injury in the community. So this is a relevant topic, specifically in our area in Africa. And it's a great honor to introduce to you our nephrology guru. And of course, he's not new here in this forum. He had presented, I think, twice or thrice in this forum. He's a former president of International Society of Nephrology from 2019 to 2021. He's also an executive director, the George Institute of Global Health in India, a chair of Global Kidney Health, Faculty of Medicine, Imperial College of London, and a professor of nephrology, head of Department of Translational and Regenerative Medicine, Postgraduate Institute of Medical Education and Research, Chandigarh. He's a Conjoint Professor of Medicine, University of New South Wales, Sydney, and this is Professor Vivek. Professor, it's a great honor to welcome you. You are warmly welcome, and we are ready to listen from you. Thank you.
Thank you, Dr. Makwabe, and my other colleagues, especially Dr. Lloyd Vincent, who is a very old friend. And I think I can lean upon him to invite me to come and join your gathering, and he will oblige me anytime I request him. As I was saying a few moments ago, it's always a pleasure to come and talk to you, not necessarily present, but just generally talk to you. And the idea is really to learn from each other, because it's only with mutual exchange of ideas and knowledge that we enhance our knowledge, our skills, and overall perhaps become better physicians, better kidney doctors, and help our patients achieve their life goals. So in the past, we have discussed some common problems. As you do, I also practice in a environment where resources are not plentiful, and our patients often have to deal with situations that they are ill-equipped to handle, both financially, knowledge-wise. But more importantly, I want to turn my attention to the other side that we don't often talk about, which is us physicians ourselves and our nephrology colleagues. Are we always well-informed and best placed to offer the best care to our patients with kidney disease or those who are at risk of developing kidney disease? Now, there is a huge amount of chatter and conversation about chronic kidney disease, and rightly so. Chronic kidney disease is a big health challenge, and it's going to increase in future. We do talk about the other cousin, which is acute kidney injury, but less so as compared to chronic kidney disease. So what I'm going to do is to focus our attention this evening to acute kidney injury, and perhaps go over some of the issues that I think I want to present to you. Some of these might sound very basic. They are, but it's useful for us to remind ourselves of a few basic things as well from time to time, because we take many things for granted. I decided to speak on identifying and managing acute kidney injury in the community. Because once a patient is already in hospital, then this challenge is much less important. It is important still, but it's less important because we have access to investigation. But managing them in the community is really where the biggest difficulty is for us. Oftentimes, healthcare workers in the communities don't even think that it may be important. So let's just talk about why it is important and what can we do about it. But before we go there, I know that in the Africa Health Network, we have not only nephrologists and physicians, but also a fair number of non-physician healthcare workers, which includes technicians and nurses and maybe other allied health professionals who take care of patients with kidney disease. So for everyone's benefit, and nephrologists can also perhaps refresh their memory, and it never ceases to amaze me to sort of remind myself how efficient an organ kidney is. Because every minute, 1,200 milliliters or 1.2 liters of blood enters both our kidneys. And this amount is 20% of the total blood pumped by the heart every minute. And as a result, if you just do the math, in one day, 1,700 liters of blood passes through the kidneys and it is purified. For those who enjoy a pint of beer at the time you have in Africa, 7 p.m., you can say that is almost 4,000 pints every day, all right? We also need to remind ourselves that an average adult has between 7 to 8 liters of blood, which is about 14 to 16 pints. So our blood volume of 7 to 8 liters passes through the kidney more than 400 times every day. So with that background, let's talk about acute kidney injury. So you can think that if the kidney is functioning so efficiently and is filtering so much blood, if there is a rapid reduction in kidney function, obviously our body, our homeostasis is not going to function as it would otherwise. So this rapid reduction in kidney function is different from chronic kidney disease because unlike chronic kidney disease, in acute kidney injury, kidney function can recover in many cases. As I posited my question to you in my title, why is acute kidney injury important? So the first thing to say is that of all the patients who are hospitalized because of whatever reason, about 1 in every 5 individuals will develop acute kidney injury. And 1 in every 10 person might go on to require dialysis. So these are huge numbers. But this may vary slightly. These are average numbers, but these may vary depending on how we define acute kidney injury and the criteria we utilize for in starting dialysis. There are a few terms that we need to recapitulate. One is acute kidney injury, which is defined according to changes in serum creatinine and urine output, according to kidney disease improving global outcomes, or KDIGO, which classifies acute kidney injury into 3 stages, stages 1, 2, and 3. It's not uncommon for us to experience, for our patients rather, to experience recurrent acute kidney injury, which is an episode of repeated kidney injury following recovery of an index case. And this may be more frequent than we realize, especially in our communities, amongst people who work in hot and humid environments, where they might be developing episodes of acute kidney injury repeatedly, which many times go unrecognized. And as a result of this, many patients will develop acute kidney disease, which is the transition between the acute and chronic states. And the acute kidney injury is defined as a period of the first 7 days. And after that, we enter into a time period where it is more appropriate to use the term acute kidney disease. And after 90 days, of course, we use the term chronic kidney disease. Now, these data, these are now almost 8 years old. This is basically a review, which shows that as the serum creatinine goes up, and you can see that on the x-axis shown here in micromoles per liter, you can do the math and convert them into metric units if you use them. You can see that obviously people with relatively lower stages of acute kidney injury are larger in number or more frequent. So this is the incidence of different stages of chronic kidney disease, going from the lowest stage to the highest stage. But on this line in blue markers is plotted the mortality. So you can see the mortality rises quite dramatically as the stage of chronic kidney disease increases, although the number of people in higher stages of chronic kidney disease is relatively low. And here you can see the same thing about increase in serum creatinine. All right. So the question that might come to you is, what causes acute kidney injury? Any condition that slows blood flow to our kidneys, any condition that directly damages the kidney, or any condition that blocks the ureters will cause acute kidney injury. Who are the people who are at risk of developing acute kidney injury? Anyone who is hospitalized, especially those who are hospitalized for a serious condition, and if they go on to require intensive care. And this is something which we have seen quite frequently in COVID-19, that ICU patients with COVID-19 were much more likely to develop acute kidney injury. Elderly people with pre-existing stenosis of renal arteries or any other blood vessels also, because that is a surrogate of renal artery stenosis. People with diabetes, hypertension, with pre-existing heart failure, pre-existing chronic kidney disease or liver disease, and of course certain cancers and their treatments, which is becoming more and more nephrotoxic. In general terms, if you wanted to present to people who do not use medical terms on a day-to-day basis in their conversations, I think you can say that presence of blood clots in veins and arteries in and around the kidneys can cause kidney damage. Cholesterol deposits that can block blood flow in the kidneys can also cause kidney damage. Glomerulonephritis, it's a tongue twister sometimes, which is the inflammation of the tiny filters in the kidneys or the glomeruli, can cause acute kidney injury. Hemolytic uremic syndrome, which is a condition that results from premature destruction of red blood cells. Infections such as with any virus like COVID-19 here. Immune disorders, and the prototype immune disorders is a condition called systemic lupus erythematosus. And not to forget, very, very important, a number of medications. And these medications will include drugs that are prescribed by doctors, such as those used to treat cancers, many antibiotics, non-steroidal anti-inflammatory agents used to treat pain, and some dyes which are used during imaging tests like angiography or CT scan. But in a country like India or in Africa, these drugs can include indigenous medicines, which are prescribed by local physicians or herbalists. Then going on to, I won't go into the detail, but there are some specific conditions also which can cause acute kidney injury. What are the signs and symptoms of acute kidney injury? Decreased urine output when present, it is a cardinal sign, but it may not always be present. When acute kidney injury is not recognized early enough and patients are allowed to progress, then they may develop fluid retention, causing swelling in legs, ankles, or feet. They may become short of breath, they will develop fatigue, and if still left untreated, they will develop mental confusion and may even lapse in coma. Some of the other symptoms include nausea, weakness. If hyperkalemia is a problem, when the potassium goes up, the heartbeat may get affected. People, as I said, can develop seizures or even coma. So the question comes, how can we prevent acute kidney injury? So the first thing to say is that we should pay attention to the labels when taking over-the-counter medications, because many over-the-counter medications such as painkillers or common antibiotics can damage the kidneys. And if you're unsure, please go to a nephrologist to make sure that we are not making a mistake when treating these patients, because they are the ones who know best how to manage kidney and other chronic conditions. And you should ask all the patients who have prolonged fever to come to medical attention and get checked, because they may have acute kidney injury as a complication of their infection, because many of these febrile illnesses are because of tropical infections in many tropical countries, which include India. One of the common predisposing conditions is badly managed pregnancy and complications of pregnancy, especially when the delivery is not appropriately managed. In many countries, pregnancy is not always supervised by an obstetrician or a physician, and many pregnant women just go to local faith healers or midwives, and even delivery may take place unsupervised, and that can cause complication. I think healthy lifestyle is an important thing that we all recognize. Now, in general, what do we know about acute kidney injury? We know that the incidence of acute kidney injury is increasing around the world, both in hospital and in the community. The good news is that the mortality from acute kidney injury is decreasing, especially in the Western world and many parts of the developing world as well. As a result of this, larger proportions and numbers of patients with acute kidney injury are actually surviving. They don't die because they have access to good treatment. And that is the good part, but the bad news for these patients is that they are at increased risk of developing chronic kidney disease, and therefore they require possibly lifelong follow-up. They are also at the increased risk of developing cardiovascular events, and of course, hypertension is increased. Just to give you some numbers, acute kidney injury develops in estimated 13.3 million people every year. And this is disproportionately larger, this burden, in developing countries. So you can see out of 13.3 million, 11.3 million cases actually present in to healthcare professionals in developing countries, or they may not present also if they don't have access to treatment. About 1.7 million people die of acute kidney injury, and once again, most of these deaths occur in low and low middle income countries. Therefore, managing, identifying, treating acute kidney injury is really important, and it is much more important for us practitioners who work in low and lower middle income countries, such as the countries in South Asia, Southeast Asia, and most parts of Africa. So I'm sure that you're all aware of this 0 by 25 initiative of acute kidney injury. And as part of that initiative, the work group developed this conceptual approach to acute kidney injury, which is called a 5R approach. And this 5R approach is focused on reducing risk, early recognition of acute kidney injury, and once the injury is recognized, making sure that we respond appropriately, provide renal support if needed, and once the patient improves, the patient is appropriately rehabilitated. Let me illustrate how we apply these 5R principles to patients with acute kidney injury through a case presentation. So here is the case: a 64-year-old male admitted with intermittent fever, loose stools, with blood and mucus. It's been going on for about a week, and now he has presented to a hospital, but he didn't report any abdominal pain, vomiting, reduced urine output, any passage of blood, or any burning and micturition. When he was examined, he was found to be pale. He had dry mucosae, indicating volume loss. He also has increased capillary filling time and some generalized muscle tenderness. You can see that his blood pressure is somewhat low and heart rate is increased, and he is a bit febrile. When the doctor took his medical history, the past medical history included a heart attack 2 years ago, and he complained, he was also known to have high blood pressure. The medications that he had been given for all of these conditions, they included aspirin, ramipril, furosemide, and simvastatin. So the first question that takes us to the first R is to identify what are the risk factors for acute kidney injury. So now we go back to the case, and here I have highlighted in a different color the features of his presentation, which would indicate an increased risk of acute kidney injury in this individual: fever and loose stools, presence of pallor, muscle tenderness, high blood pressure, tachycardia, and fever. The history of heart attack also increases the risk of subsequent acute kidney injury, and a few drugs also that the patient is taking are relevant in the acute kidney injury situation. All right. So those are the risk factors. So now, how do we recognize acute kidney injury? So we recapitulate the definition of acute kidney injury, and let me just come back to that definition in a minute. Before that, I'll tell you the investigation. So this patient's investigation showed his serum creatinine was 3.7 milligrams per deciliter, or about 300 micromoles per liter, and his serum potassium was 5.6. So the question is, does the patient have acute kidney injury? So here, let me share with you what do we need to know to confirm acute kidney injury. According to KDIGO, we need to be able to document a rise in serum creatinine by 0.3 milligrams per deciliter, or an increase to 1.5 times over the baseline. So that means we need to know the baseline serum creatinine, which is the previous serum creatinine. We need to know the current serum creatinine, of course. The other thing that KDIGO uses is urine output over the last 6 hours, according to the urine output criteria. We need to, for other reasons, we need to know the patient's weight. We need to know what is happening to the kidneys by an ultrasound. So for two reasons. One is that if the kidney is already shrunken, then it means that the patient might have a background of chronic kidney disease. Or if the ultrasound scan shows hydronephrosis, then of course we have the cause of kidney injury cleared. For other reasons, we may need to do urine sodium, urine dipstick, and we may need to do current serum urea. We'll come to that in a minute. As I said, to diagnose by the KDIGO criteria, you need to know the serum creatinine or urine output over the last 6 hours, and we need to know the patient's body weight to determine the whether urine output is acute or is adequate or not. Other information may be useful for diagnosing the cause of acute kidney injury, but by itself is not essential to diagnose acute kidney injury itself. All right. So, and now let's move to the third R, which is the response. How do we respond to a patient with acute kidney injury? And I'll now present to you this acronym STOP, right? So when we have to decide our response, we need to consider these things. Sepsis, we should always consider sepsis. So in this patient, there is fever, there is tachycardia, etc. So we should consider the diagnosis of sepsis. And we know that if sepsis is considered, then a treatment as soon as it is suspected should be started. We should also consider toxins, very important in Africa and in India. We should review the drug chart, but also take a history from the patient, right? Whether the patient has consumed anything that could be potentially nephrotoxic, including indigenous medicines also. And if the patient has been on any medications which might be causing acute kidney injury, they should be stopped immediately. The third, the letter here in this acronym is O, which means optimize blood pressure through fluid resuscitation, and if the patient is still not responding, we may need to consider vasopressors. And finally, P, very, very important, is to prevent harm. And for preventing harm, we need to identify the cause of kidney injury, and we should also identify any complications of kidney injury and treat them. So sepsis, like I said, we should treat the sepsis as soon as we suspect it. We can order total blood count and consider antibiotics. In this patient, ciprofloxacin was started. Toxin, review the drug chart and stop any medications which might be causing acute kidney injury. In this case, the patient was on aspirin, ramipril, furosemide, and simvastatin. So there are a couple of medications, at least here, which could be either causing acute kidney injury or can worsen acute kidney injury, like ramipril or simvastatin. Optimized blood pressure therapy. Remember, this patient's blood pressure was on the lower side, so start fluid resuscitation therapy, and if needed, consider vasopressors. This patient has severe dehydration, all right? And this is something which we all are very, very familiar with. So again, this may not come as a surprise to this audience. Dry mucosa, decreased skin turgor, fast heart rate, low blood pressure, all of which are present in this patient. So what should we do in this situation? We need to give the patient fluids. The ideal fluid that is considered is a balanced solution, so Ringer's lactate, but often Ringer's lactate is not available in my practice. So we freely use normal saline, and we need to start it rapidly at the rate of 30 mils per kg in the first half hour, and then you can slow down. Give 100 mils per kg in first 3 hours, and the total amount that we typically use is shown here. 200 mils per kg in the first 24 hours is the amount we often go up to. But we need to, this is not a rule of thumb that we should give it to everyone, but we should continue to reassess patients regularly. And in those who have diarrhea, vomiting, we should monitor the stool and vomit output as well. If a patient is unconscious, then we continue IV fluids until the patient is awake. And if the patient is able to drink oral rehydration solution, we should prefer to give fluids orally as well. So as I said, Ringer's lactate is the preferred solution, but often it is not available, and I use 0.9% sodium chloride or normal saline. We should not use 5% dextrose. We should also not use colloids in acute kidney injury because it can increase risk of mortality. Now, we should continue this patient's management by monitoring his clinical parameters, fluid balance, and remember that in patients who are febrile, there may be a fair amount of insensible fluid loss. We should always strive to confirm the diagnosis so that the underlying problem can be corrected and the diagnosis can be given to a patient. So just a few more details about how to manage shock in adults. The volume of the fluids that we give depends on the type of shock. If the shock is cardiogenic or obstructive, then the typical fluid replacement is moderate, about ½ liter to about 1 liter. But if the patient has had right ventricular infarction or the patient has sepsis, then they'll need to be loaded with fluids because they have, in sepsis, they have high capacity in circulation. And in right ventricular infarction, you do need to increase the preload in order to increase the cardiac output. In hemorrhagic shock, of course, you may need to give large volume of fluids and blood products may be required. So maintaining fluid balance is, monitoring fluid balance is important, and monitoring requires looking at all the inputs, which we often forget. So this includes IV fluids, medications, oral fluids, nasogastric feeds and flushes, and similarly all outputs, urine output, drain output, diarrhea, vomit, nasogastric aspirate, and any wound or stoma drainage if that is applicable. The most sensitive indicator of fluid balance is the trend in daily weights. So one of the most important things that we can do for patients with acute kidney injury is to weigh them every day, because this allows us to identify the insensible losses as well. So we all know that a normal urine output is output of more than ½ mils per kg per hour, and any volume less than 400 mils per hour is insufficient to excrete the daily solute load that we generate, and so we call it oliguria. So in any oliguria situation, the questions that we ask is the patient dehydrated? Is the blood pressure low? And this could be because of sepsis or dehydration. If the patient has no urine output or less than 100 mils per hour, then the list of differential diagnosis shrinks. And the first thing we should always rule out is if the patient is obstructed. Sometimes the cause can be really obvious. If the patient has a catheter, it may be blocked and it may need to be flushed. But then if that is not the case, then the conditions that immediately come to our mind is bilateral renal artery disease or stenosis or obstruction, rapidly progressive glomerulonephritis or crescentic glomerulonephritis, acute cortical necrosis, and of course, urinary tract obstruction. Now, the third R was to in the response is to is the P part, which is prevent harm by identifying the cause and treating complications. Let's come back to the case. After 6 hours, the urine output is 100 mils. You review the patient's investigation. The TLC or total leukocyte count is normal. There is some degree of thrombocytopenia. The blood urea is raised. The creatine phosphokinase is elevated at more than 9,000 units per liter, as is lactate dehydrogenase. All right. The ultrasound of the abdomen was normal, which meant the kidney size was normal. Malaria parasite was looked for but was negative. We also looked for dengue and leptospirosis. They were also negative. And the Vidal test, which is for Salmonella typhi infection, showed flagellar titers up to 640. And the blood cultures were taken at this point to look for Salmonella typhi. He was, of course, rehydrated, and a forced diuresis was attempted, because once we have rehydrated, we often try to give a bolus of loop diuretic to see whether diuresis can be induced in such patients. But the attempt to diurese him failed in this instance. The urine output continued to remain low, the temperature remained high, and the blood pressure didn't improve a lot, and his respiratory rate worsened. The serum creatinine was 6.1. He had severe metabolic acidosis. Serum bicarbonate is shown there, 7 millicolons per liter. He developed hyperkalemia. The potassium went up from 5.6 to 6.5. The TLC fell, and the platelet count also fell. And at this point, the blood culture returned, and it was positive for Salmonella typhi. So the question that should be asked in such a situation where a patient is being managed in a hospital is, should this patient now be referred to nephrology? So the answer is obviously yes. In this patient, acute kidney injury is severe. The patient is severely acidotic with hyperkalemia and oliguria. His kidney function has also deteriorated over the period of observation. So please try to involve a senior doctor from the patient's team, and do not delay basic supportive care in order to get a specialist opinion. I know that in your practice, as well as in my country, many times nephrologists may not be easily available. But many senior doctors are very experienced in managing such situations, even if they are not formally trained in nephrology. And they will be able to guide you how to provide basic supporting care, because acute kidney injury should be everyone's concern, not only nephrologists. So what happened to this patient? After a week, the patient continued to have fever, was switched to imipenem cilastatin, but Cipro was continued. The muscle enzyme levels improved. Intermittent hemodialysis was provided for about 3 weeks, after which the kidney function showed progressive improvement, and he was discharged from the hospital in a satisfactory condition. His kidney function apparently returned to normal. So his kidney, what will you do now in terms of follow-up? So in this situation, as I mentioned, these people are at an increased risk of developing chronic kidney disease. So he will need to return to the clinic periodically to reassess kidney function with serum creatinine tests. So therefore, my dear friends, I hope that I've been able to make these few learning points. The treatment of all individuals with any illness that can predispose to acute kidney injury, such as diarrhea, it includes a rapid and simple assessment of the level of the abnormalities that the underlying condition has produced, such as dehydration. And when dehydration is identified, we shouldn't wait and immediately start fluid replacement and management of ongoing fluid losses. A prompt and appropriate treatment of sepsis and acute kidney injury should be done. And since that was actually done in this case, the patient's condition markedly improved. Now, do remember that in this case, we did look at the elevated creatine phosphokinase and elevated LDH, which indicated to us that this patient also had rhabdomyolysis, which is the breakdown of muscles of the body. This could be secondary to Salmonella infection, but please also remember that this patient was on statins, and statins can also cause rhabdomyolysis. Now, this patient was on Ramipril, if you might recall, and in all patients who have dehydration, hypotension, and develop acute kidney injury, we stop the Ramipril, but please do remember to restart Ramipril after the acute kidney injury improves, because in any patient with cardiovascular disease and hypertension, ACE inhibitors or angiotensin receptor blockers really are essential in their long-term management. So I'm going to stop here, and I would hopefully take questions that you might have.
Thank you, Professor Jha. That was excellent talk. Really appreciate that. Dr. Marin will take over the second part on question and answers. But Professor Jha, in your situation in Africa, specifically in Tanzania, if you go to the local communities, the causes of acute kidney injury, one is dehydration, secondary to diarrhea and sepsis, of course, as you clearly pointed out. But the other commonest cause is the use of local herbs. That is, because in the village, access to healthcare is a bit limited. So they depend on the local herbs for treatment of disease conditions. So in that particular case, when patients come to the hospital, they had already developed AKI. And, most of the time you would definitely go directly to dialysis, because you will find they don't have, the urine output is significantly reduced, and you can't still wait, and therefore you have to go for hemodialysis. So I don't know if you see that picture in India as well, because in Africa, in the local community, for sure, that's the commonest in the local.
So thanks again. Yes, absolutely. What you describe is not uncommon for us. So we don't see perhaps indigenous medication-induced acute kidney injury as frequently as you do in Africa, but we do see, and there are many funny types of indigenous medicines which our patients take. For example, our patients take star fruit or other family or other members of the same family, which can cause precipitation of oxalate crystals in the kidneys, leading to acute kidney injury. There are other indigenous medicines also which can cause acute kidney injury. So, and that is why we always teach our residents and keep reminding our residents to take this history. There are other kinds of nephrotoxins, for example, copper sulfate, industrial nephrotoxins that can be missed if the treating doctor doesn't know the appropriate kind of history they should be asking. There are many such compounds which are not known by their scientific or chemical name to these people, but so it is important that we also know the colloquial name of these plants or their chemicals. So absolutely, very, very important. And the second point that you said is that many of these patients actually present to us with already fully developed acute kidney injury with complications, and they may require dialysis straight away. Another problem that this situation presents is that we often don't have any information on the baseline serum creatinine. So how do you know that whether this patient has acute kidney injury only, or that there is a background of chronic kidney disease, or that it's all chronic kidney disease? So this is tricky. So if you can do an ultrasound and the ultrasound shows small kidneys, then there is an indicator to a pre-existing chronic kidney disease, but it may not all be chronic kidney disease. There are a number of historical points also which help in making this distinction, such as presence of pre-existing anemia, evidence of mineral bone disorder, maybe long history of long-standing nocturia, etc. So they are soft pointers which suggest the presence of background chronic kidney disease. The other challenge that we face is that if the baseline creatinine is not available, according to KDIGO, you cannot make a diagnosis of acute kidney injury because it requires you to have a baseline serum creatinine unless the urine output criteria is fulfilled. In such situation, even KDIGO researchers and we in 0/25 said, because we found that this was common, that you may make a retrospective diagnosis of acute kidney injury if you can show a decline in serum creatinine if the patient improves. Now, unfortunately, that may not happen in everyone, especially in acute cortical necrosis, which we see in India, and I'm pretty sure you see that in Africa as well. As a complication of badly managed pregnancy, we can see it after certain snake bites, etc. Patients with acute cortical necrosis will develop acute kidney injury and may not recover fully. So that's a treatment. But in other patients, if you can see a decline in serum creatinine, you can make a diagnosis of acute kidney injury retrospectively.
Thank you very much, Agina, and thank you very much, Professor Jha. That was a wonderful session. And I think I would just have two questions before I start taking other questions from the floor. Professor Jha, I would just want your opinion. A lot of our physicians over here, when there's a suspicion of pre-renal AKI, they give a fluid resuscitation with some challenge with Lasix. If they're worried, this is a patient who's oliguric or anuric, they often give their first fluid bolus with a low dose Lasix. I don't know what your thoughts are on that. And the second question is on the use of these novel AKI markers, like NGAL, cysteine, and KIM1. What do you think about these novel AKI markers? Thanks.
Right. Thanks, Marian. So about your first point, yes, we do it quite frequently. So we would give, first of all, a good fluid challenge. And if the patient still doesn't produce any urine, we'll give Lasix. And I'd like to just make one amendment to what you said. We don't give low-dose Lasix if the patient is not producing urine. We actually give high-dose Lasix. So we can go up to 100 or even 200 milligrams of Lasix. But please do remember to give it slowly, not more than 5 milligrams per minute, because it can otherwise lead to ototoxicity. Because why do we give high-dose Lasix? Because the loop diuretics, they often are unable to reach their site of action, which is the loop of Henle, in patients who have a kidney injury, acute or chronic, because they first need to be filtered at the glomerulus, right? And if acute kidney injury is present, they are not filtered in sufficient amount. So you need to really load them with high dose of Lasix or loop diuretics in order to make sure that some of the loop diuretics does reach the loop, where it is supposed to act. That's number one. The second point is about the use of these biomarkers. Now, let me caution you that it sounds very exciting and people want to use it, but the practical utility of these biomarkers in patients with community-acquired acute kidney injury is practically nil. Because by the time the patient comes to you, the kidney injury is obvious. As Dr. Egina said, most patients will come with advanced kidney injury where you don't need to do any of these biomarkers. These biomarkers can have potential role in hospitalized patients who don't yet have acute kidney injury, but have undergone some procedure or are otherwise considered to be at increased risk of developing acute kidney injury, such as those undergoing a contrast administration or undergoing a complex surgery. There you may follow their parameters, which include serum creatinine, urine output, and in some situations, NGAL, etc. Why do we do this? If we do that, we may be able to take steps which will prevent the development of acute kidney injury. But I would make the point that we should be doing all of that in any case in all our patients who are at increased risk of acute kidney injury. And we should not have to wait to get a NGAL test in order to manage our patients in such a way that they don't develop acute kidney injury. So while these are good tools for research at this stage, I don't think that they're ready for prime time in our practice.
Thanks so much, Prof. That was very well explained. I'll just now start with our questions. We have one from Dr. John Philip Ngungi, and his question is, how do we measure a fluid response in acute kidney injury patients? And the second one was, if you could elaborate on your choice of fluid of normal saline over any other.
Excellent questions. So going to the first point, the first point is about how do we look for response to fluid challenge. So as I said, you have to give, first of all, appropriate amount of fluid, right? And the amount of fluid I did describe in my slides. I'm happy to share those slides with you also if that will help. And if after making sure that you have given appropriate fluid challenge, the patient is no longer dehydrated, you can look for signs of dehydration. You can look at filling of neck veins. If available, you can use bedside ultrasound to look at IVC diameter and so on. And if the patient has not yet increased urine output, then you may try Lasix, as I said before. And if the patient doesn't improve his or her urine output, then of course you realize that the patient is not going to improve. And And it's important, I didn't mention this before, that then we stop giving Lasix at that point. We don't continue to flog the kidney because the kidney is not going to respond to Lasix at that particular point of time. Your second point is also well made, that there is an ongoing debate about the type of fluid which needs to be used, and some more recent studies actually are questioning whether balanced solution is the best solution or not. And therefore, we, even though still guidelines say that balanced solution is better, there are doubts about the superiority of balanced solutions. And because of the fact that the balanced solutions are much more expensive, as I said repeatedly, that in my practice, use normal saline all the time. The balanced solutions were thought to have some benefits in terms of what they would do to electrolyte acid-base status, etc. But it's been shown to be really not that great, and therefore we don't mind using normal saline. In fact, we use them all the time.
Great, thank you, Prof. And then we have two further anonymous questions. The first one was, is there any condition that you could probably think of where you need to be more restrictive in your fluid in your AKI patients? And the second one was, what medical management would you give for metabolic acidosis in such patients as well, prior, I guess, to dialysis?
Right. So the only situation where we would be careful in giving fluids is when the patient is not dehydrated, number one, especially so if the patient has already some evidence of fluid overload, right? So that is why it is really important that we follow the appropriate steps to identify whether the patient is dehydrated or volume depleted or not. And I think I don't need to repeat the signs and symptoms of volume depletion, etc. Dehydration, you know them very well. And if they are not present, if the patients have engorged neck veins, if they're edematous, etc., I wouldn't load our patients with fluid. But sometimes do remember that even if a patient shows edema, the patient may have effective intravascular volume depletion. So giving small boluses in that situation may be still appropriate. The patient, if they have, for example, sepsis, right? So you may still need to give fluids. If the patient has right ventricular infarction, you may still need to give fluids because you need to increase the preload, right, in that situation. So that's really important. And what was the second question, Marin?
The second question was with regards to metabolic acidosis.
Right, metabolic acidosis, right. So if a patient has acute kidney injury and metabolic acidosis, the best treatment for these patients is dialysis, because generally they would have other metabolic complications, electrolyte disorders as well. So dialysis corrects everything. But if you want to manage metabolic acidosis alone, and if the patient is not fluid overloaded, please go ahead and give soda bicarb. You do know that the formula for using soda bicarbonate, so you need to calculate the base deficit, and then at least correct half of that. And in most instances, that by itself will not be enough, but it will help you buy some time. But please do remember that if a patient, if you give them soda bicarbonate, be mindful of serum potassium, because soda bicarbonate will push potassium into the cells, and the patients may become hypokalemic. So unless the serum potassium is raised, look at serum potassium, and if serum potassium is low or even normal, you may want to give some potassium before starting soda bicarbonate.
Okay, very interesting. Then, Professor Jha, we have a question all the way from Afghanistan. We have Dr. Ahmed Nasser, who's sent us two questions. He says that they see a lot of postnatal acute kidney injury. Is there any recommendation you have for its prevention? And secondly, the benefit of doing urinary electrolytes, he says they're not readily available to them in Afghanistan. If you could comment on that.
Right, thanks, Dr. Ahmed. Welcome to this meeting. So you are right. Unfortunately, we also see postnatal acute kidney injury in India and in many other parts of South Asia. I'm pretty sure it's seen in Africa as well. It's really a reflection of relatively poor maternal care that our patients receive, pregnant mothers receive, unfortunately. So the answer to preventing acute kidney injury in this situation is to provide better care for pregnant women, better care during pregnancy, especially to those with high-risk pregnancies, such as those who develop high blood pressure or gestational diabetes. But of course, all pregnant women should receive medical care, and they should have institutional delivery, which means delivery in a healthcare facility to the extent possible, because most of the complications develop after delivery or during delivery. So that's the period of greatest vulnerability. The second situation, which I used to see when I was a fellow very commonly in India, was after an abortion in women. But thankfully, that has become much less frequent now because abortion was legalized, and so therefore abortion is performed now in a safe environment. But if there is unsafe abortion, then of course they are at increased risk of developing acute kidney injury. So what the best that we can do is to really appeal to our governments, to our policymakers, is to improve the quality of care that is available to pregnant women. Really, that's very important. Now, how often do we do urinary electrolytes like sodium? We don't really do it very much, although it is used. It's described in terms of its ability to distinguish between renal acute kidney injury and renal acute kidney injury or acute tubular necrosis. But in practice, if you have seen sufficient number of patients with acute kidney injury, you will know by clinical parameters, by history, by some basic investigation, whether it is pre-renal acute kidney injury. So that should be, that should not be required. Doing urinary sodium to distinguish between these two conditions. So don't worry about doing urinary sodium.
Okay, then Professor Jha, moving on to our next set of questions. We have one from an anonymous that asks you if you have any concerns about worsening of fluid overload in giving sodium bicarbonate. And the second one is what's the best approach in identifying AKI if you have you don't have a baseline creatinine?
Right. So the first question, absolutely, there is a risk of worsening fluid overload. So that's why I said that if the patient is not fluid overloaded, then you give soda bicarbonate. If the patient is fluid overloaded or is at risk of developing fluid overload, do not give intravenous sodium bicarbonate without starting dialysis. So the treatment in that situation is dialysis. So even with dialysis, what are you doing? You are actually introducing bicarbonate into the patient's body, right? So if the patient is not fluid overloaded, then the best thing to do is to just give intravenous sodium bicarbonate. But if the patient is volume overloaded or is at risk, then you give dialysis. Don't give intravenous sodium bicarbonate by itself. What is the best approach to identifying AKI in the absence of baseline serum creatinine? It's your clinical judgment. So you have to see what is the plausibility of acute kidney injury in a given clinical scenario. So you need to be familiar with all the conditions which predispose to the development of acute kidney injury, many of which I described. Many of them are specific to your practice. And so just familiarize yourself. And just to recap a few of them, they are anything that produces volume depletion, anything that can cause nephrotoxicity, which includes over-the-counter medications, herbal medications, chemicals, any kind of acute febrile illness, any bites by any snakes, etc., or other animals, badly managed pregnancy. These are a few of the conditions. Post-operative, any blood loss, these are, and of course we should always remember obstruction, because obstruction requires a different management and it gives you very gratifying results.
Okay, Professor Jha, your talk has elicited so many questions. It's amazing. We still have two more, if you don't mind. We have a question from an anonymous saying, how do you differentiate ATN and cortical necrosis clinically? And the last one is, what are your comments on dose adjusting nephrotoxic antibiotics when treating sepsis? Thanks.
Right, thanks. Very good questions, both. So taking the difference between acute cortical necrosis and acute tubular necrosis. So the hallmark of acute cortical necrosis is severe and prolonged anuria. So if you see any patient who presents with anuria, which is urine output of less than 100 mils, quite often I see patients who fail to produce any urine at all. So the urine output is close to zero. And do remember that anuria can also develop in severe acute tubular necrosis, but that anuria is usually transient. It lasts for 1 or 2 days, and then the urine output starts to improve. But if anuria is persistent, lasts for more than a week, and certainly for more than 2 weeks, then the suspicion of acute cortical necrosis becomes extremely, extremely strong in this situation. The second thing you should keep in mind is that there are certain predisposing conditions where acute cortical necrosis can develop more frequently. And they include post-obstetrical acute kidney injury or postnatal acute kidney injury, bites by certain animals, such as snake bites, sometimes during pancreatitis, and very rarely following severe sepsis also. So pancreatitis, severe sepsis. So these are the situations where you should keep acute cortical necrosis in the back of your mind, and certainly if the patient shows no improvement in urine output after 2 weeks, acute cortical necrosis becomes very strong as a diagnostic possibility. And the way to make a diagnosis, if available to you, you can do a contrast-enhanced CT scan, and there are typical abnormalities described. You can look at our publications, and which shows hypo-enhancing cortex, which is almost diagnostic of acute cortical necrosis, or you can do a kidney biopsy if it is available. Your second question about dose adjustment, absolutely very, very important. Any person presenting with acute kidney injury should always adjust the dose. And please remember, here is a tip, which is very important, which is different between acute kidney injury and chronic kidney disease. In acute kidney injury, you should always adjust the dose as for anyone with an GFR of less than 10 mils per minute. Because remember, acute kidney injury means a total shutdown of kidney function. So a total shutdown of kidney function doesn't lead to an immediate severe increase in serum creatinine. So if the serum creatinine is 1 at baseline and the GFR becomes 0, the next day still the serum creatinine will be only 1.5 or 2, right? But the GFR is still 0. So at that time, if you have to give antibiotics, please adjust it according to this GFR parameter, right? So this is very important. Whereas in chronic kidney disease, because that is a stable situation, you will have to calculate the GFR according to either the Cockcroft formula, or you can estimate the GFR using another formula. But for acute cortical necrosis, always adjust as for a GFR of 0.
Thank you very much, Professor Jha. That was such an engaging and informative discussion. I think our audience really appreciated that as well. And I would like to thank you for giving us your time today. I know how busy you must be. We really appreciate it. And we look forward to having many more such fireside chats with you. And on behalf of the entire AHN team, I would like to thank you for coming and spending this hour with us, and look forward to many more. Thank you very much, Professor.
Thank you. I really enjoyed this conversation and happy to come back any other time.
Thank you very much, Vivek. Extremely grateful.